Welcome to the Deep Dive, the show where we take complex science and really just boil it down to what you need to know.
Today we are on a pretty fascinating journey. We're going to follow a single medication from the moment it enters your body to the second it actually starts to work.
Yeah, it's like this hidden chemical battle that happens with every pill you take, and this all falls under the umbrella of pharmacology.
Right, which is, simply the study of how substances interact with living things.
So it's about finding these little switches in the body, these molecules, and then flicking them on or off.
Exactly. And to get that, you need to understand two key concepts. First is pharmacokinetics, or PK.
Okay, PK.
That's what the body does to the drug. Think of it as ADME. Absorption, distribution, metabolism, and elimination.
And the other side of that coin
Is pharmacodynamics, PD. That's what the drug does to the body. The actual effect, like Tylenol bringing down a fever. PK is the logistics. PD is the action.
Okay, let's unpack this. Our mission for this deep dive is to walk through those 4 PK steps, see how the body tries to fight back, and then end with something really cutting edge. Pharmacogenomics.
Which is all about why your own personal genetic code might determine if a drug helps you or hurts you.
Let's start at the beginning then. Absorption. This is just getting the drug from, say, your stomach into your bloodstream.
It sounds simple, but the route you take is a huge deal.
How so?
Well, if we inject a drug intravenously with an IV, absorption is 100%. It's instant. It's all there.
But when you take a pill, it's a different story. It has to survive your stomach acid, get through cell walls, deal with whatever food you just ate.
It's a gauntlet. And that's where we get the concept of bioavailability.
Which is just the percentage of the drug that actually makes it into your circulation, right?
Exactly. If you take a 100-milligram pill and only 70 milligrams gets into the blood unchanged, its bioavailability is 70%. We have to account for that loss.
And here's where it gets, I think, really wild. The body's first line of defense. First pass metabolism. So the body is actively trying to destroy the medicine.
You completely nailed it. Before the drug can get to the rest of your body, it gets absorbed from your gut and makes a mandatory stop at the liver.
The liver acts like a screening agent.
A pre-screening customs office. It just starts breaking down the drug immediately, sometimes before it can do any good at all.
And that's why some drugs, like nitroglycerin for chest pain, can't just be swallowed.
Precisely. If you swallowed nitroglycerin, the first pass effect would destroy almost all of it. The oral bioavailability is terrible.
So we have to, I guess, trick our own biology?
We do. We give it sublingually under the tongue. The tissue there is full of blood vessels that drain directly into the main circulation.
It's bypassing the liver entirely.
Completely bypassing that first pass problem. And the result is relief in, 1 or 2 minutes, which for angina is absolutely life-saving.
Okay, so the drug is absorbed. Now it has to get out of the blood and into the tissues. And to do that, it has to cross cell membranes.
And most drugs do this using the simplest method, which is passive diffusion.
Moving from a high concentration to a lower one, no energy needed.
Right. But, and this is a huge, but it only really works for drugs that can dissolve in fat. They have to be lipid soluble and uncharged or non-ionized.
What if the drug isn't? What if it's more water soluble?
Then it needs help. It might use facilitated diffusion, which is like having a specific doorway, a carrier protein, but still no energy. Or it uses the heavy-duty option, active transport.
And that one does use energy.
It uses ATP, yes. And it can actually pump a drug against its concentration gradient, from a low concentration to a high one. It's how we force drugs across really tough barriers, like into the brain.
You mentioned drugs needing to be uncharged. Why is that so important?
Well, think about what a cell membrane is. It's a layer of fat, a lipid bilayer.
Like oil and water.
Exactly. A charged, water-soluble molecule just can't get through that fatty layer. So an acidic drug, for example, is best absorbed in an acidic place like the stomach, because that environment keeps the drug in its uncharged, lipid-soluble state.
Got it. Okay, so once it's in the blood, we get to distribution. Where does it all go first?
It follows the blood flow. So organs that get a ton of blood, the brain, the liver, the kidneys, they get the highest initial concentration of the drug.
And some of those organs have barriers, like the famous blood-brain barrier.
A huge one. The capillaries in your liver are very leaky. They have holes. But in the central nervous system, the CNS, the cells, are fused together with these tight junctions,
making it incredibly difficult for things to get in. So how does an anesthetic like thiopental work so fast? It must cross that barrier easily.
It does. Thiopental is extremely lipid soluble, so it just zips right across into the brain.
And its effect is famously short. Does the body just break it down really fast?
That's what you'd think. But no. Its short duration is actually a perfect example of distribution. It doesn't get broken down, it just runs away.
Runs away where?
It rushes into the brain, causes the anesthetic effect, and then it quickly redistributes from the brain into tissues with less blood flow, like muscle and fat. The concentration in the brain drops, and the patient wakes up even though the drug is still in their body.
That's amazing. Now, you also mentioned a protein problem.
Yes, in the blood, many drugs bind to proteins, especially one called albumin. But here's the key. Only the free, unbound drug is active.
The part that's bound to the protein is just cargo?
It's inactive cargo, exactly. And this can lead to some of the most dangerous drug interactions out there.
Like the warfarin example.
The classic, terrifying example. Warfarin is an anticoagulant, a blood thinner, and it's highly bound to albumin.
Okay.
Now, say you start taking another drug, like a sulfonamide antibiotic, that also likes to bind to albumin. It can actually kick the warfarin off the protein.
And suddenly you have more free, active warfarin floating around.
Exactly. Even a tiny increase, 1 or 2%, can double the amount of active drug, sending the anticoagulant effect through the roof and creating a massive risk of bleeding, all from just competing for a parking spot on a protein.
So, after all that, we get to the cleanup phase, metabolism and elimination. This is mostly the liver's job.
Right. And the goal is simple. Make the drug easier to get rid of, which usually means making it more water-soluble.
But sometimes metabolism is what turns a drug on.
Correct. Those are prodrugs. They're inactive compounds that your liver has to process to turn them into their active form. Codeine being converted into morphine is a perfect example.
And the liver does this in 2 phases, phase 1 and phase 2.
Phase I is all about modification, adding or exposing a chemical group to make the drug a little more polar. Then phase 2 is conjugation.
The big cleanup step.
The big one. The liver attaches a huge water-soluble molecule to the drug. It's like slapping a giant shipping label on it that says, to the kidneys.
And the main engines for phase I are the cytochrome P450 enzymes, the CYP enzymes.
The absolute workhorses. Just one of them, CYP3A4, metabolizes something like half of all drugs on the market.
Wow.
But their activity can be changed. Some drugs can induce them, making them work faster and clearing other drugs too quickly. Others can inhibit them, slowing them down and causing a dangerous buildup of another drug.
So once the drug is tagged and ready for shipping, it goes to the kidneys for renal elimination.
The most important route out. And it involves 3 steps: filtration, secretion, and then a potential problem: reabsorption.
What's the problem?
Well, if a drug was lipid-soluble enough to get into the body, it's also lipid-soluble enough to just diffuse right back out of the kidney tubule and into the blood again.
So the body could just suck it right back in. How do we stop that?
With a brilliant biological hack called ion trapping.
Ion trapping, okay.
We can actually change the pH of the urine to force the drug to become ionized or charged while it's inside the kidney tubule.
And because it's charged,
Get across that lipid membrane to get back into the blood, it is chemically trapped and forced out in the urine.
and this is used in real life.
Oh, all the time. In an aspirin overdose, aspirin is an acidic drug. We give the patient sodium bicarbonate. That makes the urine alkaline, or basic. The acidic drug becomes ionized in that alkaline environment, gets trapped, and is cleared from the body much, much faster. It's a life-saving intervention based on pure chemistry.
Let's shift to timing now. Let's talk about half-life. That's the time it takes for the concentration of a drug in the body to drop by 50%.
And most drugs follow what we call first-order elimination. A constant percentage of the drug is cleared over time.
Not all of them.
No. A few very important ones follow zero-order elimination. This means a constant amount is eliminated, regardless of how much is there.
And why does that happen?
Because the enzymes doing the work get completely saturated. They're working at max capacity. Think of ethanol, alcohol, or high-dose aspirin.
What's the danger there?
You lose predictability. If you double the dose of a first-order drug, you roughly double the effect. If you double the dose of a zero-order drug, you might triple or quadruple the duration and risk severe toxicity because the body simply can't clear it any faster.
That clearance speed also determines when we reach what's called steady state.
Right, which is just the point where the amount of drug you're taking in equals the amount your body is clearing out.
And there's a rule of thumb for this, isn't there?
There is. It takes about 4 to 5 half-lives to reach a clinical steady state. For a drug with a long half-life, like tanoxicam for arthritis, that could be 2 weeks.
You can't ask a patient in pain to wait 2 weeks, so we cheat.
We cheat. We give a loading dose, a large initial dose, to get the blood concentration up to the therapeutic level right away. Then we follow it with smaller maintenance doses,
Which brings us to safety and the therapeutic index, or TI.
which is just a ratio. It compares the dose that causes a toxic effect to the dose that causes a therapeutic effect.
So a big number is good. A large TI, like for penicillin, means there's a wide margin of safety.
A very wide margin. But some drugs have a narrow therapeutic index. Warfarin again, digoxin, lithium. For these, the effective dose and the toxic dose are dangerously close together.
Which is why patients on those drugs need constant monitoring.
Constant blood tests to make sure they're in that very narrow, safe, and effective window.
So we've covered the journey, the PK. Let's touch back briefly on pharmacodynamics, the PD. The drug is at its target. What does it do?
It binds to a receptor, usually a protein, and the type of receptor determines the speed to the response.
Some are super fast, like milliseconds.
Like the ones benzodiazepines use to calm the nervous system. But others are much slower, like intracellular receptors.
The ones inside the cell.
Yes, for drugs like steroids that have to be lipid-soluble to get inside. They work by changing gene expression, so the response can take hours or even days to develop.
Which brings us to our final and maybe the most important topic, pharmacogenomics. The ultimate link between the drug, the body, and you, the individual.
It's the study of how your specific genes affect your response to drugs, especially those CYP metabolism enzymes we talked about.
Because we're all a bit different in how fast our enzymes work.
We are wildly different. We group people into categories. Most are extensive or normal metabolizers.
Yeah.
But some are poor metabolizers, maybe 5 to 10% of people. And a few are ultra-rapid metabolizers.
So a standard dose is really just a guess based on an average person.
It's a statistical guess.
Right.
Take the blood thinner clopidogrel. It's a prodrug that needs the CYP2C19 enzyme to be activated.
So if you're a poor metabolizer,
You don't activate the drug, you don't get the therapeutic benefit, and you could be at high risk for a stroke even though you're taking your medicine every day.
and the opposite problem can happen too.
Absolutely. Think about codeine. It's a prodrug that gets converted to morphine by a different enzyme, CYP2D6. If you're an ultra-rapid metabolizer, your body converts that codeine to morphine way too fast and way too much. A standard dose could be like a massive overdose for you, risking fatal respiratory depression.
It just shows that the journey of a drug isn't standard at all. It's intensely personal.
Completely unique to each of us.
So we've covered this whole chemical landscape, from the liver acting as a gatekeeper to the body's clever use of ion trapping to get rid of drugs.
I think the biggest takeaway is how connected it all is. You learn that if a patient's kidney function goes down, the drug's half-life automatically goes up.
And you immediately know you need to adjust the dose to avoid toxicity.
It's direct, actionable knowledge.
So what does this all mean? When you think about this huge genetic variability, this spectrum from poor to ultra-rapid metabolizer, it really makes you wonder, how much longer will medicine be about prescribing for the average person?
It forces the question, doesn't it?
It really does. How close are we to a future where every single prescription is tailored not just to the condition, but to our own unique genetic blueprint and metabolic speed?